So firstly, thank you, Gordon, Sarah, the sponsors, for the gracious invitation to speak. Thank you also, Jeff, for your very generous welcome to country, which was really extraordinary. And finally, thank you, Angeline, for introducing the idea of trust, because a large part of what I'm going to talk to towards the end of my presentation is going to be talking about the issues of public trust. So I've titled this "The Ethical Challenges of Science at Warp Speed." This draws from work that I've been involved as a collaborator, and obviously also draws from science fiction. So, sorry. Right. So some disclosures. As Gordon mentions, I'm a clinician and bioethicist, and was also involved in as an original director of Praxis Australia. The key ones for me here are really the last couple. The first is that I have been involved in helping draw up policy guidelines for intensive care management and resource allocation in the context of the COVID-19 pandemic, fairly unsuccessfully, I would add. The other is that I'm involved in a series of research studies looking at different aspects of COVID-19, principally not just ethics and governance, but also interventions including convalescent sera and vaccination or protocols for vaccination. Now, this is a photograph of me. For those who know me recently, this photograph is a lie. This is what I used to look like. I'm considerably more haggard now, and this is what I would like to look like. So I like this. It says, "Always be yourself unless you can be Captain Kirk," in which case, be Captain Kirk. So I'm going to try and channel a little bit of Captain Kirk today. So what I'm going to do is basically go through the challenge created by the COVID-19 pandemic, and then outline how science has performed at speed, but then suggests that there are challenges that result from that. And there are two types of challenges: challenges within science and challenges to science and outside of science. And the latter in particular, I think, is creating a significant legitimacy crisis for science, not just in this country, but globally. And I'm genuinely unclear how that can be resolved, but I think it is one that's going to create a much more long-lasting legacy, arguably, than some of the ways that clinical trials landscape and the research landscape has changed in Australia. So some facts that I think everybody is familiar with. These are very much up to date. So as of this morning, 262.2 million people infected worldwide, with a little bit over 5.2 million deaths. Depending upon interpretations, we're at least in the fourth, probably in the fifth wave of the pandemic in different countries, and we're now facing more variants. The response of the scientific community and of science generally to this terrible pressure has been remarkable. Within 6 months, there are 165 candidate vaccines for COVID-19 at speeds of development far in excess of any previous infectious disease. And now we have a little bit over 3.3 billion people fully vaccinated, 7.9 billion doses administered at rates of 29 million a day. So that's the population of Australia being vaccinated every single day. The disparities here are worth noting, with 54% of the world's population receiving one or more dose, but in some parts of the world, 5% or less having received a single dose. At the same time as we've seen vaccinations being developed, we also now have therapies being developed in an area where often therapies have taken decades to be developed or not developed at all. So in other words, in relation to respiratory viral disease. We've also seen a remarkable transformation of the hospital system and remarkable performance in some countries, and particularly this country, of our public health system, with obviously some exceptions, with aged care, the disability sector, and the health systems available to Indigenous Australians being much poorer. So there's been this unprecedented explosion of science. Now, to enable that, there's been an extraordinary upscaling or fast tracking of every part of science. And I just wanted to flag these because I will come back to the challenges raised by this. So research funding, trial registration, trial design, ethics approval, governance, conduct of studies, rapid publication, all of these have been facilitated. To the extent, and again, just to give some numbers, because these numbers give some weight to the types of challenges that emerge. So a publication every 4 minutes, greater than 200,000 papers on COVID, almost 1 million authors on COVID. I have to raise my hand here. I've been involved in authoring some studies on COVID-19 as well, although I'm clearly not an expert in virology or epidemiology or anything of the sort. Within a year, there are almost 2,000 clinical trials registered just in Australia, many of those interventional studies. Within 1 month of the pandemic, the majority of the world's medical journals had agreed to have a global open access policy to allow rapid availability of information regarding the pandemic. The preprint registries that existed were given a massive impetus by COVID. So bio and med preprint registries have now become the major source of scientific information on COVID. And that's a transformation that's happened within 18 months in the scientific publication sector. The implications of that for peer review in standard journals have halved, and in preprint registries, the time to publication online is in the order of 1 to 3 days. The impact of this has not just been within the scientific sector, however. Importantly, it's also been out into the public domain. So just looking at social media metrics in terms of notices and tweets, so looking at Twitter and Facebook, is that papers dedicated to COVID-19 now dominate the most widely shared, cited and downloaded papers in history. So the impact of this rapid science has been rapid dissemination of data about COVID-19. In terms of the clinical trials landscape, we've seen the same kinds of pressures operate. So the clinical trials sector, for those involved in the sector itself, as opposed to its regulation and governance, has been remarkably transformed. Safety concerns have been implicated or have been taken account of in relation to clinical trials with rapid decisions about suspension, termination and continuation. Trial visits have been reduced, clinical trial endpoints have been simplified, remote visits have been enabled, home trials, including home blood draws, home delivery of therapies, even home imaging has been facilitated in ways that hasn't been the case previously. Local blood draws and imaging as opposed to centralisation has happened quickly. Remote data capture and involvement of remote consent has happened. Flexibility in recruitment, e-consent, and some, although admittedly much less than we would expect, rethinking of innovative clinical trial designs has occurred as well. So again, huge changes. Now, all of that looks like a story of success. And I have to say is that just if we look at vaccinations, the therapies, already the hundreds of thousands of lives that have been saved by this scientific progress, it is a success. But there's a series of questions here that I think we have to ask. The first set will be ones that I'll actually just flag and then won't return to again. And that is, why weren't we prepared for this? So Ross Upshaw and colleagues from the University of Toronto went back and looked at our previous pandemics, looked at Zika, looked at SARS, looked at all of the outbreaks of Ebola, and asked this question: how did we confront each of these pandemics? And we confronted them in the same way. We said these were a wake-up call, we needed to get structures of rapid research happening, and then they disappeared. Right, so we'd had pandemics before. We know what pandemics do. We know that they expose fissures in society that are pre-existing, fissures on race, fissures in socioeconomic capacity, fissures in access to healthcare. We know all of these things. So we know how pandemics can impact upon populations and subpopulations. We knew that we would need speed for the next pandemic. We had pandemic plans. We knew the populations that would be vulnerable. We had research expertise in this country and elsewise. We had facilities for dealing with infectious diseases, and we'd seen modelling for infectious diseases and pandemics fail before, particularly in relation to Ebola. So I think there's a series of questions that we would have to ask about how prepared were we with our pandemic preparedness, right, in ways that actually potentially have now created a problem as well as created a solution. But the second set of questions is the ones that I'm going to go to now, which is that have we actually gone too fast? Or another way to put it, are we actually approaching warp speed? So for those fans of Star Trek, which is the area that popularised warp speed. So warp speed is the point at which maximum speed is reached beyond which matter will distort and either create harm or lose its function. There were ranges of different types of warp speed 1, 2, 3, 4, and 5. I have no idea what the difference is between each of those things, presumably speeds of warp speed. So the question therefore is that in speeding up science to deal with the pandemic, is that have we actually reached a point where there are harms emerging from speed? And I think there is. Now, I want to take a little bit of a step back, and shortly I'm going to step a long way back, which is to suggest that there's actually has been this pressure on science and ethics and on governance to be faster, leaner, more effective, more productive, to serve economic and public and scientific ends more quickly for decades. So this is not a new phenomena, but the pandemic has just hastened this further. It's brought this need for efficiency, this need for speed into the public domain and into the scientific domain, into the ethics domain, into the governance domain in a much more accelerated fashion. And it's worked. Right? So speeding up science has worked. It's certainly worked in relation to this pandemic, but we can always go faster. Right? So at any point we can change the way we do trial design. We can change the way we run trials. We can change the way we regulate them. We can change the way we publish them. Is that we can do this all of the time. So for example, on drug registration, we can skip animal studies. We can just do computer-based or stem cell culture-based modelling. We can skip phase 2 studies altogether or combine them with phase 3 studies. We could allow market entry with coverage with evidence development schemes, and so accept lower levels of evidence. And we could accept that we don't have any need to do national review, so we could accept the drug and regulatory reviews done by other countries. We can do trials that enabled far more limited ethics review. We could do it by protocol. We could do it online. We don't need to have committees involved at all. We could divert our research funding away from absolutely everything else, because arguably that can wait in the context of a pandemic. And we can make science entirely open and move it into the public sphere. We can generate our data and make it all available in the public sphere. We can always do these things. The question becomes, at what point does it create harm? I want to suggest that there are signs of warp speed, changing function and creating harm. And these relate to, very broadly, to the links between research and commerce, to the notion that science and research in and of themselves are good, as opposed to good science and good research. That peer review and its reduction may actually create harm if it's lost or diminished in importance. And similarly, that ethics review and governance may create harm if it becomes diminished in importance or lost. And finally, and possibly most controversially, that actually there may be harms from opening up publication, data sharing, communication, and accessibility. So what are these types of challenges? So the first one is that we are seeing poor quality of studies. So many of the studies, and particularly in the first year of the pandemic, were underpowered, were poorly designed, recruited very poorly. Now, how many studies were of poor quality is hard to know. Some estimates go as high as greater than 95% of the studies done have been of poor quality. Work done by Johns Hopkins, for example, found of the first 40,000 studies, only 80 were of sufficiently high quality have actually moved on understanding about COVID-19. We've seen profound duplication of studies around the world. Within the first 4 months of the pandemic, there were 165 clinical trials of hydroxychloroquine in the United States alone. Similar duplication has been reported in this country as well. There was certainly a misdirected focus of studies, with many more studies directed to treatment rather than prevention, to tertiary sectors rather than rural and remote communities. We've had the challenge of volume overload. With the sorts of numbers that I put up before, it was clearly impossible for anybody or even any entity to synthesize and translate this data into practice or into policy. So we had to quickly draw up processes using algorithms or artificial intelligence to mine literature and to create collated digital collections. The process of dissemination without review has caused some problems as well, right? With the rapid uptake of non-peer-reviewed data within sectors far outside, as one would expect, far outside the scientific sector, and I'll come back to that. And we've seen significant failures of peer review and also research misconduct. Possibly the best known of these is the Surgisphere debacle, where a paper that actually used a cloud-based database that had been generated by this company, Surgisphere, reported data from over 10 countries, trying to generate data on whether hydroxychloroquine was effective. This found that hydroxychloroquine was of no benefit and potentially created harm in the context of COVID-19. But importantly was not so much the trial and its rapid publication, but the finding very quickly that there were problems with methodology, with data integrity, with failures to declare conflict of interest, and even with research misconduct with some data just simply fabricated. This led to these two papers being rapidly retracted from the journals that had published them, the Lancet and the New England Journal of Medicine. So in other words, fairly small impact factor journals. But by that stage, the damage has been done, right? And this debacle was picked up by proponents of particular types of therapies, and particularly hydroxychloroquine, by Jair Bolsonaro and by Donald Trump, as evidence not only that hydroxychloroquine worked, but actually also that there was some type of conspiracy being waged by the medical community, science, and big pharma to prevent the public having access to proven therapies. So those are the types of challenges that were happening within science. But I want to suggest that actually the challenges to science were actually occurring in every sphere of life. And these are the ones arguably that are going to have a broader impact. So in the public sector, in the government sector, in the media, and in healthcare more generally, we've seen this emergence of concerns about science. So suspicion of science, rejection of scientific claims of truth, the clear promotion of untrue or unproven statements, the promotion and regulation and use of unproven treatments, particularly ivermectin, which has been regulated and made available in more than 10 countries worldwide. Resistance to vaccines, not just COVID-19 vaccines, but of all vaccines, and not so much stemming from concerns about adverse effects, but concerns about the science on which these vaccines were based. And finally, we've seen a refusal to consider the wider impacts of the pandemic because of concerns about whether science can be trusted to do this, because of concerns about whether government can be trusted to do that, or a disinterest from all parties to do it. Right? So a failure to address the moral issues that I mentioned before, the potential causes of these pandemics like climate change, and even a reluctance to consider whether the reforms of science and ethics that have happened over this last 10 to 20 years to increase efficiency have actually paradoxically caused the types of harms that I'm describing. Now, some of these types of critiques of science have actually intersected. So we hear discussion of these types of suspicions in every family conversation, in workplaces, in the professions, online, in the broadstream press. And because science communication is faster and more accessible, more open, is that not only is that attractive, but it actually also foments these kinds of claims that are now being made about true and untrue science. I mentioned before that that COVID-19 has fomented the emergence of these preprint service and registries. So importantly, these are the principal source of science communication about COVID-19. So what we're seeing then is non-peer-reviewed, at the point that they enter the public domain, claims made by science generally, right, about COVID-19. And because those messages are diverse, because they're heterogeneous, because some are true and are not true, and because some come with, or arguably all come with some type of research question or research goal or research agenda, is that these types of claims about science are then linked to xenophobia. So particularly anti-Chinese initially, and subsequently broadly anti-Asian, but also then anti-Semitic rhetoric. They're linked to conspiracy theories about government, about scientists, about the process and norms of science, about big pharma. They're linked to right-wing philosophies. They're linked to anti-vaccination positions. And finally, as I mentioned, they're linked to the promotion of therapies that have no proven evidence basis, and arguably have caused harm. We have more than 250 serious poisonings of ivermectin just in the United States alone. Now, this is despite the fact that one of the manufacturers of ivermectin came out and said that it has no evidence base to support its use in COVID-19. That made not a difference in terms of the promotion of ivermectin. So these are really powerful messages that science cannot be trusted, or that the information that it's putting out is amenable to different types of political discourse. Now, the implications therefore of this are a couple. The firstly is that we've seen significant erosion of moral authority, not just of science or medicine or public health, but also our ways of knowing, right? And the social institutions linked to them. So the research institutes, the universities, the health departments that are all linked to science are distrusted. And we've seen this spectacular emergence of distrust. So we have a serious legitimacy crisis. And this is playing out in the placards in Melbourne, in Sydney, and online. We're seeing this everywhere. This is not a US problem or an Austrian problem, a Belgian problem, a German or a French problem. This is an Australian problem just as much. We're also seeing, though, an ethical crisis. So we're seeing a new form of public sphere, a new form of discourse, new ideas about what is acceptable. So rather than have argumentation or debate, what we're increasingly seeing backed up by the types of scientific claims is just an assertion. Right? Ivermectin works. Vaccines are dangerous. Vaccines will cause infertility. There's no necessary link with logic, with data. These are assertions. That's becoming the dominant form of argumentation. And in the place of science, in the place of ethics, in the place of integrity, in the place of democracy, what we're not seeing, though, is a credible or coherent alternative. In other words, a different way that you generate truth, or a different way of coming up with ethical discourse. That's absent from the field. So I want to step back just for a few slides to say, look, where has this critique of science come from? And I want to suggest that we can actually take it back to the Enlightenment project. So at the European Enlightenment, science introduced really novel ideas about rationality, that distinguished it from religion, from aesthetics, and so forth. And these became rapidly universal. So these intellectual forms, these intellectual ideas about ways of knowing and what constituted truth, they laid the basis for emerging capitalism. They laid the basis for the industrial changes that were spreading rapidly around the world. And it transformed everything. It transformed our physical environment. It transformed our social environment. It allowed the development of extraordinary technologies. It changed the way that we organised industry. It created the basis for the pharmaceutical industry in the subsequent century. And then it generated an extraordinary amount of wealth. And what it suggested is that underpinning this was that it was girded by a concern for human well-being and for freedom. This would actually free us in different ways. Now, the tragedy of this Enlightenment project is that it came with costs. There was destruction of the urban and natural environment, the elimination or marginalisation of non-rational ways of thinking, of the emotions, of different types of social discourse. The individual became dominant. Society became alienated from nature, which was something to be controlled. Traditional cultures and ethics became marginalised, dismissed and destroyed. And we created the perfect means of waging war as well as creating health. Now, this prompted a series of critical responses, and I think we can see residues of these responses in Melbourne, Sydney, and the United States and Austria. So we see critiques of the very notion of truth, of reason, of rationality. We see critiques of the idea that science should be and can be objective. We see critiques of the mechanistic ideas of understanding the body, of mechanistic ideas of understanding organ function and physiology. We see critiques of not just individualism, but also utilitarianism and the idea that we have a metric by which we can determine what we should do. We see critiques of liberalism, of the market, of capitalism, of managerialism. Some of the things, again, we saw around the global financial crisis as well. And we can see these in the discourse surrounding COVID-19. Some of these images, I think, are striking, right? The stop destroying our children's lives, right? And that's principally around social isolation, rejection of the very notion of a pandemic, rejection of the very notion of COVID-19. For those working in the clinical interface, they may be shocked, as I was last week, when a patient came to see me and not only refused a recommendation to be vaccinated, but denied the very existence even that there was a pandemic in place, or that there were vulnerable other individuals in our hospital who could be harmed by infection. It was a concrete denial made categorically on the basis of a scientific claim emerging from science that was in the public domain. So what we're seeing now is a loss of confidence in the independence of science and scientists, and it's driven by money, right? And it's working against us. Interestingly, of course, is that same money is creating the production of ivermectin, but that's a logic that often escapes those who are arguing against vaccination, but in favour of ivermectin or hydroxychloroquine. We're seeing a loss of confidence in or public uncertainty about the very ideas about government and public health, right? It's restricting us, or it's against us. It's anti-libertarian. It's against freedom. It's against rights. Right? We're seeing a deep skepticism about the social institutions that support the construction of knowledge and truth. So medicine, particularly, is in the sights, if you want, of this type of critique, and then science more generally. Right? We're seeing an emergent interest, again, of alternative treatments for COVID, irrespective of evidence. Evidence, again, is not the issue here. Right? It's trust and mistrust and alternative truths. We're seeing uncertainty about vaccines, again, some of which initially reflected adverse events concerns, particularly in relation to the clotting risks of the AstraZeneca vaccines, and subsequently to immune type risks of the Pfizer vaccine, and Moderna to a lesser extent. But that's not the main cause of vaccine uncertainty. It's mistrust of the very science that generates the possibility of a vaccine in the first place. So we're seeing a deep questioning of the moral basis of power and authority. Right? And then finally, we're seeing the pandemic become the focus point for expression of sort of wider inequities, wider suspicions, wider frustrations, wider expression of powerlessness, particularly from the far right and marginalised groups, but also from groups who have a very valid claim and a historical claim for marginalisation and dispossession. Some of these images will be immediately familiar to people. The immediate association now of George Floyd with the Black Lives Matter movement, with the pandemic, has become an important touch point for identifying questions of race. But I want to suggest that they have, in a way, been marginalised by this distrust of science as well. Now, there is a paradox here, and a paradox in these counter movements, because I want to suggest that these are valid concerns in some ways. So there are valid concerns and there are valid critiques that can be advanced against big science, against bureaucratic science, against racist science, against big medicine, and against medicine as an instrument of social control. So for those who know or are interested in the history of research and medicine, there's a terrible history that reflects all of these things. So the links with science and research, with government, with business, with the pharmaceutical industry, all of those things reject or project valid concerns. And similarly, they project a loss of a sense of ethical purpose or community. But again, the rejection of this notion of truth is not part of development of an alternative concept of truth. What instead we're seeing promoted is falsity, which is a different thing to an alternative truth. And what we're seeing in this rejection of established ethical frameworks, or the notion of respectful community discourse, is very degraded ideas about notions like freedom and human rights. So these valid concerns, corruption, hypocrisy, power, authoritarianism, exploitation, managerialism, the panopticon, so the capacity for bureaucracy and government to observe people in all their domains of life. And all of those things have not generated an alternative program or optimized social movements or political movements to revise economic structures. Right? They also have been derailed, arguably, despite initial progress through the Black Lives Matter movement. And similarly, is that we haven't seen really clear process to having what I believe would be a valuable and important discourse about racism and power, or about discourses of climate change, for example, as a cause of pandemic. Rather, instead, what we're seeing is quite bizarre, in my view, discussions about the Wuhan laboratory being a source of this entire pandemic. In ways that are redolent of the weapons of mass destruction argument, right? Which was something that created the mechanism and the argument in favour of going to war in the Middle East, but was subsequently shown to be not something that had a strong basis. Arguably, the Wuhan lab situation is one that has even less basis in truth. And we're not seeing construction of novel ethical discourses instead, right? What we're seeing again is this alignment of science, open science, rapid science, warp speed science, with different types of agendas as truth statements. So I want to conclude, therefore, with some remarks about where this leaves us. Right? So leading from this is that the type of science that has produced data, and I'll use data rather than evidence, in relation to hydroxychloroquine and ivermectin, right, has not produced alternatives. These aren't actually alternatives. They're not being put up as a rigorous, considered, evidence-based option. They're being put up as a choice based on claim statements or rhetoric or polemic, right? and these don't refer to COVID-19 necessarily, is that the alternatives aren't even alternative discourses or about truth and ethics. They're just alternative statements. So these aren't necessarily linked to different types of rationalism, different types of inquiry. Right? And as I mentioned, vaccine resistance arguably is not a discussion about rational responses to concerns about adverse events of vaccines, or even arguably about the process of scientific development that led to vaccines, but an indication of a much deeper and a much more profound loss of confidence in society, a loss of confidence in science, a loss of confidence in government, and a loss of confidence in the very possibility of collective public solutions to public crises like a pandemic. So the general effect of this is what we're seeing is a loss in foundational ethical values: trust, responsibility, loyalty, solidarity, reciprocity, responsibility. For those, and I think probably many of you listening would, like me, have been shocked and continue to be shocked by the intensity of the public revolt in Melbourne and the demonstrations in Melbourne. The really disquieting parts of those are not the discussion about COVID-19. It's the deep discontents of government, of authority, of public health, of departments of medicine, of science, of public health systems, and of others that those demonstrations have given voice to. So where do we go from here? So I think COVID-19 has exposed the benefits of rapid science, but equally I want to suggest that it has exposed the risks of warp speed science and of pushes to increase efficiency and increase speed in science research, publication and public discourse, potentially beyond the point at which creates principally benefit to the point now that it's arguably creating harm. And that harm, again, I want to suggest, is not the harm to clinical trials, it's the harms to public trust and public discourse and public ethics. And even arguably that our efforts to make them faster ourselves, our efforts to make peer review faster, to make publication faster, to make science more open and more democratic, to be more co-constructed, to get out there into the public domains without necessary peer review so that people, the reader themselves, can interpret the data. Maybe all of those things have had unintended side effects. Right? The other aspect here is that we have seen that COVID-19, like all pandemics, has provided a diagnostic lens for us to examine our societies and look at the way that culture, politics, science, and ethics intersect. So it's exposed fault lines. Fault lines of race, of age, of welfare systems, but also of science and government, and it's highlighted our vulnerabilities. It highlighted our vulnerabilities in relation to power and race and health systems. In this country, arguably, it's highlighted problems with the way that we fund and manage our aged care system. It's highlighted the ways in which we create access to welfare for people with a disability. It's highlighted the very ways that we regard disability, and it's certainly highlighted our ongoing failure to take seriously questions of race and access to healthcare. Right? And it's also exposed our lack of available alternatives. So although we've identified problems with politics and science and all of these sorts of things, what's come in its place is not a new, more democratic, more ethical type of science and government, but arguably one that's more politically corrupt. An ethics that's more devoid of meaning than one, in fact, that we've had previously. So we still haven't addressed these deeper malaises, our inability to really take seriously climate change and colonisation in this country and so forth. So where do we go from here? I was going to actually finish on here and say, actually, I can't think of a way out, but I want to suggest that there are some. So how can we boldly go where no man has gone before? Because possibly this is, I would think, one of the more profound points of rupture in the trust in science and the relationship that science has with society that we've faced. These are just some suggestions. I think we do need to create capacity, right? So we need to not be in a situation like we have been with previous pandemics, right, where we say we must learn from this pandemic and prepare for the next, but not be. So we do have to have in place fast-track processes, protocols that are shared and transparent and open, procedures and SOPs for doing research that are shared and open and critiquable and transparent. We have to hold fast to some notions of scientific and ethical rigor, including review. Arguably, we have to take on board the utilitarian challenge, and we have to think of what are all of the risks of rapid science, right, and rapid governance. Right? When we were thinking about the risks of rapid scientific evolution of vaccines, arguably there was not a lot of discussion about the possible creation or fomentation of deep loss of trust in science as a result of potential issues that have emerged with vaccines. But arguably that is the kind of thing that we do need to take into account. We need to think about what is gained and what is lost each time we reform ethics and governance and science and publication and make it faster and more democratic and more open. We do need to think of ways to address this legitimacy crisis, and this is not just within science, this is much more broadly. We need to try and reconstruct public discourse and arguably rein in and revalidate our consideration of what human rights actually means, and we do need to address the divisions that exist and learn from our moral failures, including arguably in between pandemics, than be surprised every time like a goldfish in a fishbowl that sees the castle on every circuit. So with this I'll finish, and I do want to thank some colleagues of mine that who've helped me think through these issues. So to Paul Komisarov, to colleagues at the University of Sydney, to colleagues at Praxis, and also to colleagues at the Central Australian Aboriginal Congress as well, I would like to offer my acknowledgement and thanks. And finally, I want to thank also the organisers, but also point to a session that Gordon and the organisers have organised this afternoon, being given by Philomena Horsley and Sally Armstrong from Praxis, that's presenting the idea of self-evaluation by research ethics committees. So Gordon, I'll stop, and happy to take any questions if we have any time.
Thank you. Look, you know, as always, polemic, thoughtful, and didactic. And you know, I don't think anyone would disagree with your position. And I guess the question is always, how do we move forward, you know, in a way that reflects contemporary views, but also ensuring, at least from our perspective, how we do our job properly. Now, we do have some questions, but I will, of course, make some. There have been some thank yous from Sue Wilson, an amazing opening keynote. Thanks to the organising committee, and thanks so much to a great Captain Kirk, and someone with whom you'll be familiar who works for the NHMRC in Canberra, and I will not mention his name, Jeremy Kenner. Not so much Kirk, but more Picard. Okay, and an important point actually, which was that when you suggested to boldly go where no man has gone before, it was correctly pointed out that perhaps it should be where no woman has gone before either. And I think that's actually incredibly important, because it does reflect, you know, sort of society, but also in terms of what we do on ethics committees, that, you know, people's views are incredibly important, and perspectives are incredibly important. And I thought that was actually quite a salient point. Now, at least I did want to say, at least if people use ivermectin, then you know they might get rid of parasitic worms, I suppose, but you know, perhaps not too much else. Okay, we do have a couple of questions, Ian. One from Melanie. Great presentation, Ian. How do you think this era of public mistrust in science and authority will impact the practice of human research ethics? Beat me to the punch there, Melanie. Will there be a demand for more transparency of decision-making processes in a public domain?
Look, paradoxically, and it actually it goes back to a point that Angeline made before, because she also pointed to the collapse in public trust. So paradoxically, in fact, this may cause us, and I hope personally that it does, cause us to reflect on whether there's at least the possibility of losing ethical rigor in some of the processes that we've established to hasten science. And again, I don't want to suggest that I'm against hastening science. Clearly I am, right? And the pandemic bears that out. But I think there are genuine questions now as to whether in the way that we've sped up science, but also sped up its translation and dissemination. And I think that is a really key issue here, because not only do we get it done quickly, but we get it out quickly. And then the rationale for that was to leave it open for everybody to do their own peer review, to have democratic and immediate and rapid and transparent processes of communication. But that's coming back to bite us, right? It's bitterness from the presidents of the United States and the president of Brazil, but it's coming back to bite us at the individual level in this country. So you know, I found it very distressing over the last series of months that patients are presenting to me, and I would like to hope that many patients I have a good relationship with, but their response to the way that I talk to them now is quite different. In some ways, you know, I'm seeing a distrust of what I'm saying if they perceive that I'm on the side, if you want. In fact, even the idea that there is sides is an unusual idea. But if I'm on the side of big pharma, or if I'm on the side of research, or even worse, if I'm involved in research, then that's a bad thing. Right? So I think we do have a real challenge here, and I think it is one that the whole clinical trial sector is now going to have to deal with.
Yeah, Ian, and look, I firmly believe so. Last year, COVID or whenever, you know, I'm fairly sure many people on this call would have had similar situations where they had to get through a study pretty quickly. And I'll put my hand up and say, you know, we got through a study, albeit hydroxychloroquine, because these things hadn't been retracted, within 48 hours, right? So approved by ethics. Yeah. I still believe we maintain sufficient rigor in that process. I even got external people involved in this process. So I guess one of the questions is, you know, we should, and I think we should be able to do things more quickly and more efficiently. Completely take your point about this translation. The translation is just, you know, that's clearly where the risk is. But do you think then, A, we should be able to do things more quickly? Have we been being over-regulated or putting brakes on ourselves? And you know, if you go to an ethics meeting, there's 2 applications, you'll still take 2 hours to discuss them because you have plenty of time. You know, do we get into that paradox?
That's a great question, Gordon. Can I maybe start by suggesting ethics and governance review, of course, just one small part of the process by which the scientific idea, you know, generates then a therapy or a vaccine, right? And you know, I've mentioned the problems with dissemination and translation, major problem. The other big problem, obviously, is in the conception of the research question and then the design and conduct of the study. And you know, so it's not the ethics committee's fault, right, that within a couple of months we had 170 almost identical trials of hydroxychloroquine that were underpowered, and never able to generate you know, evidence of any value, and subsequently didn't. Right, so that's not the fault of an ethics committee. It's the fault of the scientific process, definitely, but it's not the fault of an ethics committee. But arguably, there is some point where an ethics committee, and you know, and I'm including scientific review as part of an ethics committee's remit here, would be to look at a study and say, is this adequately powered that it's going to produce any type of useful knowledge, right? So in which case, you know, if it isn't, then it's you know, it's beholden, I would think it's beholden on the ethics committee to say, look, we're feeling a lot of pressure to push this through, but this doesn't look like something that's going to contribute knowledge. It's going to contribute noise. Right? So I think in that way, I think, yes, ethics committees have been complicit in this process as well. Do I think ethics committees could do things faster in the appropriate situations? Absolutely. Pandemics is a great example. Rare diseases is another good example where arguably an ethics committee should do something faster than arguably it's done in the past. Can it be done faster and yet sort of not lose ethical rigor? Yes, but there's a point at which you do start to lose ethical rigor. And I think we just have to accept that. I mean, I gave the example of clinical trials or a series of clinical trials saying, look, let's just forget phase 0, preclinical animal studies, do phase 1, phase 3, straight to market. Of course we can do that. You know, arguably, anytime you do that, though, your increased likelihood of causing harm, and there's lots of evidence where this is the case, goes up. And I think the same happens with ethics review as well.
Thank you. And we have a couple of questions from the audience, and I will ask them to ask them themselves. So Gigi Sutton, if you wish to unmute yourself and ask a question, if you have one. And until Gigi's ready, let's get Indrani Ganguly. Indrani, if you can unmute yourself and ask your question.
Thank you for a wonderful talk. I'd just like to ask if you have any comments on what's happening by countries like India and China, which have large scientific communities. The level of transparency about the spread of COVID, I think, varies, but they also engage in vaccine diplomacy, and China's just, and with what the potential for this is in terms of worldwide trust or power imbalances. Wow,
that's Indrani. That's such a wonderful question, and I'm definitely, not the a political philosopher or a politician at all to answer that. But I would like to offer a couple of comments there in relation to the scientific aspects of this, because of course what we saw prior to this and what we've seen interestingly is really what's been called vaccine nationalism. So the generation of vaccines with very limited amount of data sharing between Russia, China, the United States, and so forth. So we've seen a degree, not just at the point where there are now vaccines available and produced in large mass, but also the very generation of the data leading to the vaccines in the first place, both the preclinical data and subsequently the clinical data. Now, how that's played out, though, has gone in different directions. And in a way, of course, this maps on to foreign policy more broadly. For some countries, and China in particular, India to some extent as well, there has been the idea of using vaccines to provide global benefit, both for commercial sort of self-interest, so commercial ends, but also for a self-interest that actually works in everybody's interest, which is reducing the amount of COVID-19 in one particular part of the world. And that's the issue that's playing out in South Africa at the moment. The other, though, of course, is that it's been used in the opposite way. So our country, as you know, we diverted some of the stockpile of Pfizer vaccine to Australia to ramp up our vaccine response at one stage. And we've had arguably not a great track record of delivering vaccines at the point where other countries desperately needed them as well. So we haven't done as well as other countries have done, not just in relation to aid more generally, but also in relation to COVID vaccinations. So I think they've got definitely ethical potential, but they've equally been used fairly egregiously in terms of self-interest.
Thank you, Ian. And one from Roberta Littleford here. With regard to the concepts you've addressed, legitimacy and ethics crisis, alternative truths, etc., do you see these concepts influencing and impacting consumer engagement contributions? How should research groups, HRECs, consider potential bias?
Yes, I do. And again, because truth statements or scientific claims are being mirrored alongside particular political positions, which is what we're seeing in Melbourne and Sydney in the United States and in Europe incredibly egregiously on the streets of Austria and Belgium in this last couple of weeks, as many people will know. So we're certainly seeing alignment with particular interests. Look, I think arguably the same types of things that ethics committees should want to see in the development of scientific proposals now, we will need to attend to again in the future. So we will need to see respectful community participation. We'll need to see ideally informed engagement and co-design between scientists and community advocates as well. And arguably with that process, you would hope that will generate something that's informed, that's meaningful and provides community benefit. I think it will get more complex, and I think it is going to be more complex now, but I think that basic tenet still holds true.
Yeah. And thanks, Ian. I mean, your point about human rights was interesting because it's clearly something that is underplayed. And, you know, I'm not sure about everyone online, but certainly in most ethics meetings I run, I at least do in my head, you know, this mental risk assessment about how human rights might be impacted by these decisions, and only because I happen to know the Queensland Human Rights Act pretty well. But it's not, you know, it's not de rigueur. It's not something everyone would necessarily do. And I think it's incumbent upon us to actually understand, you know, such legislation and its impact of research. And there's a question here. Is there any role responsibility for ethics committees to mitigate redundant research, thinking of the extensive duplication where individual studies are underpowered and the quality may have been higher if a few large studies? So that's from Joshua Wiley. But I think
I'd be happy to respond to that one. Yes. Yep. I mean, look, that always gets ethics committees into trouble, isn't it? Right? I mean, I support, Gordon, as you know, I support the idea that ethics committees inevitably have to make judgments about science. Right? It's not just about, you know, how attractive the consent form looks. It's arguably a statement about, is this well designed? Is this going to generate the outcome of interest? Has it been designed respectfully with the community at large? It's all of those things. So they're questions of science as much as they are of ethics. If something is a study that is not going to generate the data, particularly the data that it claims to generate, then that's a really important ethical concern. So, you know, how ethics committees can actually get the evidence upon which they can make that judgment, that's a harder thing to do. But I think it's still possible, even by looking at a trial in and of itself, to look at the ways in which its powers, its statistical analysis, to make those kinds of judgments, and then push it back to the researchers and get them to respond to those questions.
I mean, I would probably add to that to say that I believe we probably get applications for clinical trials way too early. In doing some work I'm doing in another sphere, it's really about setting up, you know, methodology, people able to provide advice on methodology, empowering studies. I think if an ethics committee was able to get that information at the time to say this has been through this process, you know, we'd be in a much better position, because then we wouldn't have to rely on someone on the committee who, you know, might know a bit about statistics, etc. So I think there are ways around this. I think as ethics committees, we can, you know, we can help to mitigate this distrust by possibly improving the process before something comes to us. And I think until that happens, we are leaving ourselves a little bit open, because then all we do is we look at what's in front of us instead of saying, well, kind of, you know, who has looked at this before? Okay, so Ian, that is...